We'll call to order the House Standing Committee on Appropriations and Revenue. Welcome, everyone. Meeting number 2, Tuesday, February the 24th, 2026 at 12 p.m. Eastern, Annex Room 154. And if you will, please call the roll.
Representative Banta.
Present.
Representative Bojanowski.
Here.
Representative Bridges.
Here.
Representative Brown. Representative Burke.
Here.
Representative Dietz.
Here.
Representative Fleming.
Present.
Representative Freeland.
Here.
Representative Fugit.
Here.
Representative Hart.
Here.
Representative Lockett.
Present.
Representative McPherson.
Yes.
Representative Riley. Representative Stevenson. Representative Thomas.
Present.
Representative Truitt.
Here.
Representative Upchurch.
Here.
Representative Williams. Representative Bowling.
Here.
Representative Bray. Chair Petrie.
Here. Okay, having a duly constituted quorum, we'll continue with business. Any member have a special guest that they want to recognize? Didn't check in advance. I apologize. Anybody? Representative Burke.
Thank you, Mr. Chairman. It's my distinct honor and pleasure to welcome and introduce a woman who needs no introduction whatsoever, my predecessor, the good and honorable Kathy Stein.
Welcome, and if everyone will welcome her. Thank you very much. Any other member? Seeing done, seeking recognition for that purpose, we'll move into the agenda. We have House Bill 1, and with presenters, we'll approach the table, please. Sponsored by Representative Kimberly Mosier. An act implementing the Federal Education Opportunity Program in Kentucky. And if each of you will, one, make sure your mics are really, really green and close enough to you when you introduce yourselves for the record, and please do so.
Thank you, Mr. Chairman. I am Kim Mosier, State Representative for the 64th District.
Very good, thank you.
Thank you, Mr. Chairman. TJ Roberts, Representative for the 66th House District.
Very good. If each of you will raise your right hands, do you swear or affirm to tell the truth, the whole truth, and nothing but the truth?
I do.
Very good. Thank you. Again, make sure that when you're presenting, the green light is really green. Its microphone's close enough so the record can pick you up. And on House Bill 1 we have a committee substitute.
Motion on the side. Second.
We have a motion and a second on committee substitute. All in favor? Well, I'll hold before we do that. Representative Bojanowski? Sure.
So in the sub, you took out the language exempting deductions for qualified contributions from Kentucky taxes. Can you explain the impact? Does that mean that individuals who donate to a scholarship granting organization get a federal tax credit and a state deduction?
No, and I'll take that. There was a committee sub drafted at my request, and on Section 2 was not necessary as a tax credit. On the original bill was included with tax deductions in Kentucky. One, it did not fit. Number two, tax credits at the federal level do not flow to the state, does not affect tax returns in the state. Tax deductions would. This is a credit, so it was unnecessary. Any other questions?
No.
On the sub?
Yes, sir.
Representative Burke?
Could you please briefly explain the difference between PHS 1 and PHS 2?
Okay,
Oh, no, that's for Medicaid.
Apologies.
a rephrase or withdraw?
Withdraw the question, thank
Thank
you.
you very much. Anybody else? All right, we're back on the motion and a second on the adoption of the sub PHS 1. All in favor? Aye. All opposed? Sub is adopted. That is what we have before us for consideration. Please proceed.
Thank you, Mr. Chairman, and thank you, members of the committee, for giving us a few minutes to discuss this very important piece of legislation. House bill would simply allow Kentucky primary and secondary students K through 12 to take advantage of scholarships available as a result of the Federal Education Freedom Tax Credit. This is a program that was established by Congress under H.R. 1 this past summer without the expenditure of state dollars. This measure would provide a significant tool for public schools to harness a federal tax credit to assist families and children access school resources. It affirms our commitment to expanding educational opportunities and improving student outcomes. For years, too many Kentucky students have not met expectations, and more than half are not reading, writing, or doing math at grade level. Beginning in the 2027 tax year, this new initiative establishes a tax credit scholarship program designed to give families greater access to K-12 options that best fit their child's needs. Federal law already allows Kentuckians to take advantage of this dollar-for-dollar tax credit of $1,700, but unless Kentucky opts into the federal program, it's not available to Kentuckians. House Bill 1 and the Educational Freedom Tax Credit would not cost Kentucky taxpayers a dime, but it would allow Kentucky students to take advantage of scholarships granted by scholarship granting organizations, or SGOs. You'll hear us talk about those today. Under this model, public schools could establish their own independent scholarship granting organizations to collect donations, just as they do with as any nonprofits like PTOs or athletic boosters, to administer those SGO funds. So what the bill does is it authorizes the Secretary of State to opt Kentucky into this federal program. It will also allow the Secretary of State to administer the program. The bill allows private donors to make a donation to a nonprofit scholarship granting organization in Kentucky and receive that dollar-for-dollar tax credit up to $1,700. These donations to an SGO in Kentucky simply bring more money into Kentucky and to Kentucky schools and benefit Kentucky families and children. This is a federal tax credit, and so we are paying federal taxes anyway. So this is a way just to redirect some funds back to our state. So if we don't do this, we're leaving money on the table.
Have a motion and a second on the bill as amended by the sub. Anything further to present?
Is there anything you'd like to say?
Mr. Chairman, I welcome any questions that the committee might have.
Very good. We do have a pending motion, a second on the bill as amended by the committee sub. Representative Bojanowski, did you have a question or comment?
Yes, sir, I do.
Please proceed.
All right. So my question is, could a scholarship granting organization be established that by its establishment only gives scholarships to public education students?
Representative Bojanowski, the answer to that question is yes. The allowed educational expenditures under the statute that establishes this program, which is 26 U.S.C. Section 25F, cross-references 26 U.S.C. 530B3A for what they are permitted to establish. It specifically lists off a multitude of education-related expenses, but it is clear that it allows for public, private, or religious schools. So if a school district wanted to establish its own SGO to specifically benefit the schools in that district, it can.
One more question, if I may.
Please proceed.
So I've read a lot of bills since I've been here, but this is the first one I've seen with this language. What does the 11th Amendment immunity clause mean in practice?
Certainly. So Representative Bojanowski, a waiver of 11th Amendment immunity means that claims relating to this act can be litigated in federal court. We found that proper given that this is about the rollout of a federal tax credit. We believe that federal courts are more well equipped to handle matters pertaining to federal law.
Thank you. Any other member? Representative Burke.
Thank you, sponsors, for bringing the bill. I appreciate the opportunity that we have before us. My question is this. Some of the best legislation that I've seen happen here has been brought by one of the sponsors, and she is always interested in gathering data so that we can make better informed decisions in the future. would the sponsors be amenable to an amendment that simply gathers data about the students who are benefiting from this and the public institutions or private institutions which benefit?
Well, I think the Secretary of State is already equipped to collect data. I mean, they're who is setting up the SGOs, and so as far as the scholarships that are appropriated, I believe that they would already be collecting that data. Do you have any other information?
Yeah, there's requirements throughout that issue, but on top of this, one of the concerns that I would have with a state data collection beyond the federal is the Kentucky Supreme Court has boxed us in significantly in terms of this. If we add language that would expend any general funds, that would open it up to a challenge on that issue. And as a result, I would be hesitant to go beyond what the federal government currently allows for and what the SGOs currently do.
Thank you.
Any other members seeking recognition for comment or question? Representative Truitt?
Thank you. I guess my question is, elementary principal. All right. I've got students that need some extra help after school. All right. Or maybe I've got, during the summer, I've got some students that maybe I'm worried about and I would like to feed them. All right. Is that something that would be possible now with this legislation?
Is that a policy question or your school question?
Both.
Both, that's what
Okay.
I'm thank you. Please
There you go.
proceed.
Oh, you do? Okay, I was just...
Yeah, so Representative Truitt, I thank you for that question, and the answer is yes. So subsection 1 of 26 USC 530 B3A permits for tuition, fees, tutoring, special needs services, books, supplies, or other equipment in connection with enrollment or attendance at a public, private, or religious school. So on that end, yes. Subsection 2 also allows for uniforms, transportation costs, or other supplementary items which are required. Subsection 3 even gets into internet access, broadband, other issues to ensure that these students can get the materials that they need, the special assistance that they are in need of. So this would actually address that issue, yes.
One follow-up,
Please
Chairman.
proceed.
So could the school be this SGO, or would it have to be an outside source to do so?
The school,
Separately.
The public school?
The school would be schools would be allowed to set up an SGO. So it would probably come from the school district because under the law, an SGO has to benefit at least 2 schools. So if there's an elementary school and a middle school, that covers that requirement. But yes, a school district can set it up as long as it is a 501c3 nonprofit and it is solely service to serve the students under that SGO. That is permissible under federal law.
Thank you.
Very good. Thank you. Representative Riley?
Thank you, Mr. Chair. A question I'd like to ask is, if someone grew up in a rural, poor county, but they moved and they now live in more affluent county, are they allowed to designate that money will go back to where they grew up?
Well, a donor can designate that their funds go to any specific SGO, but it wouldn't necessarily follow the child if that's what you're asking.
No, I'm not asking about following child,
Oh,
but would
just-
that money be able to go back to the district
Yes.
from which they grew up?
Yes, it would.
Okay. Thank you.
And I may just ask for a clarifying point following Representative Riley. SGOs are created independently of school districts and others. Now,
Correct.
school districts could be involved, but those SGOs, the SGOs set up their own internal criteria of how each one will operate. They all need not operate the same. They have different targeted student populations, all kinds of characteristics. And then it's up to the SGOs to go find donors that match what the SGO is attempting to do by way of assistance with those internally designated characteristics. Is that fair?
That is correct.
Okay, so if I have someone from a really poor community and moves to an affluent community and moves to one side of the state and back to the other side of the state, whenever they find an SGO that mirrors their desires to help out in education in Kentucky, they contribute to the SGO, they receive a federal tax credit, and our kids are assisted. Is that correct?
That's right.
Very good. Representative Fugit?
My question's been answered. Thank you, Mr. Chairman.
Any other member seeking recognition for comment or question? Seeing none, please call the roll. Yep.
Representative Banta.
Pursuant to Constitution 57, I need to record an abstain.
Please note.
Representative Bojanowski.
Pass.
Representative Bowling.
Yes.
Representative Bray. Representative Bridges. Representative Brown.
Pass.
Representative Burke.
Pass.
Representative Dietz.
Yes.
Representative Fleming. Representative Freeland.
Yes.
Representative Fugit.
Yes.
Representative Hart.
Yes.
Representative Lockett.
Aye.
Representative McPherson.
Yes.
Representative Riley. Representative Stevenson.
No.
Representative Thomas.
Aye.
Representative Truitt.
Yes.
Representative Upchurch.
Yes.
Representative Williams.
Yes.
Chair Petrie.
Yes. House Bill 1, as amended by PHS 1, having received 16 yes votes, 1 nay vote, 3 pass, and 1 abstention, will be reported with favorable expression that same should pass on the floor. Thank you both very much. Next up, we have House Bill 2, an act relating to Medicaid, making an appropriation therefore, and declaring an emergency. Sponsor, Representative Ken Fleming. And as you approach the desk, if you will, make sure that the green light is really green, microphone is close enough to you. Introduce yourself for the record officially, and we'll place you under oath. Go ahead when ready.
Mr. Chairman, I'm Ken Fleming. I represent the 48th District, which covers Jefferson and Oldham County.
Very good. Welcome. Raise your right hand. Do you swear or affirm to tell the truth, the whole truth, and nothing but the truth?
I do.
Thank you. And we have, I believe, a PHS 2. Is that correct?
Yes, Mr. Chairman, we also have a committee amendment on that.
Committee Amendment 1.
Yes, on PHS2 that was distributed to the members. I would like to make a motion to approve the amendment to modify PHS2.
Have a motion
Second.
and a second to approve Committee Amendment 1 to PHS 2. I'm sorry. It is in the packet and it has been distributed, but yes, question? What?
Could you explain the amendment?
The amendment addresses, in the original, on the bill, actually, the sub, it has MCOs going from 5 to 3, and we changed that to what it currently is, which is B5, or whatever the administration deems to be necessary when we go through a procurement process in a couple of years.
So that amendment removes any effect
That's correct,
by
yes,
the
sir.
committee sub upon that particular issue.
Yes, sir.
Very good. Any other question? All right, we have a motion and a second for approval of Amendment 1 to PHS 2. All in favor?
Aye.
All opposed? Committee Amendment 1 to PHS 2 is approved. Now, we have PHS 2 as amended by Committee Amendment 1, adoption of the amendment taking place, as amended PHS 2.
Motion to adopt PHS2 as amended by the committee amendment. Second.
We have a motion and a second for adoption of PHS 2 as amended by Committee Amendment 1. Representative Bojanowski.
Yes. My question on the amendment or on the committee sub is, has it gone in front of the Medicaid Oversight Advisory Board, and do we have a fiscal
We
note?
talked about that. The Medicaid Oversight Board and recommendations were made by that board, and those findings and recommendations have been incorporated into this bill.
And do we have a fiscal note?
There is a fiscal note.
Look
yes.
in your packets. There will be fiscal notes on each of the two bills that were being presented today.
I will do that. Thank you.
You're welcome.
Anything else? Representative Burke?
Thank you, Mr. Chair. A question, if I may.
Yes, is this on the adoption of PHS 2?
This is the differentiation between PHS 2 and PHS 1. I'm wondering if PHS 2 contains in section 1 the,
Wait a minute, I'm sorry, make sure I understood what you said. Is this a comparison of a PHS 1 and a PHS 2? PHS 1 is not before this committee.
I'll withdraw the question and ask it later. Thank you.
Thank you. Anyone else? All right, we have a motion for adoption of PHS 1 as amended by committee, PHS 2 as amended by Committee Amendment 1, and a motion and a second thereon. Anyone else? All in favor? Aye. All opposed? We have PHS 2 as amended by Committee Amendment 1 adopted, and that is before us for consideration. Representative Fleming, please present.
Thank you very much, Mr. Chairman and the committee. Medicaid is a significant and important program that we have, and this Medicaid basically started in 1965, and the primary purpose was to provide low-income individuals, elderly and disabled folks who could not afford a private health care. And throughout the years since 65, there have been over about 23 different modifications that affected Medicaid. And this most recent one is House Resolution 1, which the previous speakers mentioned that. And part of that, House Bill 1, it looks at a broad spectrum of Medicaid issues. Let me try to put this in perspective. What we have is a Medicaid budget has nearly doubled, in fact, over doubled over the past 5 years to an unsustainable level that we've got to do something in terms of addressing the cost of this, but also maintain the integrity, maintain the quality of service that we provide those who are least among us in order to make sure they receive the proper care. In order to do that, that increase represents about 216% of taxpayers' money increase. And so we need to look at that very, very closely. There is a whole host of issues that came about in terms of thus being unsustainable. Basically, it revolves around the adoption of the expansion of Medicaid, to loose eligibility determinations, poor data and resource management, lack of oversight, basically incentivizing organizations to bring people more on to the expansion process, inefficient processes, and duplication of functions, lack of accountability. People have taken advantage of the administration in terms of its liberalization of its policies. And also, if you look a step back, where have we progressed in terms of our outcomes? We have really not progressed a whole lot. And so in effect, we're putting a lot of money out there to almost $24 billion in order to try to make a impact to help people out and get them in a better spot when it comes to their health outcomes. So this House Bill 2 looks at two components. One, as I just mentioned, House Resolution 1. That has a lot of criteria, involves community engagement, cost sharing, eligibility, integrity, and several other things. So that's one component that this bill addresses. The other component addresses program integrity. There's a lot of issues and situations that we have seen that have surfaced throughout our investigation at the Medicaid Oversight Board, and we need to take some corrective action in order to help get a more transparent, more accountable, more responsible Medicaid program. So let me just take a little second let me take a moment and to go into those roughly speaking provisions in the sections. But let me first back up and say this is for expansion Medicaid population. Expansion doesn't deal with and address a lot when it comes to traditional population. And so it takes into consideration, and it doesn't include quite a few folks in the population. That includes children, pregnant and postpartum individuals, caretakers, disabled veterans, substance use disorder, serious complex medical conditions. So it takes a lot of that information, and in the expansion population, we need to look at, have a little more control of that. So let me just take 1 second, or let me go ahead and get into the sections. But prior to doing that, there's been a lot of talk and a lot of discussion about fraud in the media and talking to folks. This takes a serious look, and there's a lot of embedded processes and procedures within here to look at fraud and making sure that our system's not being taken advantage of, and making sure that there's some incredible integrity and process that in order to provide the best service possible to those who are least among us. Some of those fraud preventions includes out-of-state, stronger eligibility data source, includes having a person direct payments under a case manager. It looks at checks for redetermination and so forth. So let me first of all address the community engagement. Right now, we do not conform to the federal law. This basically codifies what HR 1 is in terms of how do we need to address that. The other things that we look at is regards to, well, let me back up. So basically, as I mentioned, the main issues is compliance with the federal law, while we're trying to preserve some legislative control on this. There are a couple items in there. One is that when it comes to demonstration of folks that are on, that will be required, that identified by the DMS, that they need to go through and be, qualified to continue to get Medicaid. There's basically two things. One, if you're new coming into the program, you basically have to work at least 1 month. If you're existing in there, you have to work 3 months in order to continue the service. Now, if a person is basically disenrolled, they have the opportunity to go through that process for appeals process in order to do that. The second thing is there's cost sharing. Cost sharing, once again, we don't adhere to the federal law. And in the cost sharing, and compared to what we originally did, we basically narrowed down the cost sharing is basically of a couple of two things. One, we have seen a significant increase in people using emergency room for non-emergency services. So we have gone through and adopted the federal law, which currently is around $8 per person in order to go through that. And what we're trying to do, we're trying to change the behavior of an individual. So when somebody goes in, we're trying to get them to go to the primary care, where under this particular law, there is no cost sharing. And so we're trying to shift people from the emergency care over into seeing their primary care physician. The other is having a $35 inpatient hospital stays. What we're trying to do, we're trying to adjust the cost shifting of the situation. So let me address two things. One, you might say, well, what about cost, the cost sharing, the co-payments and so forth? That's going to help hurt individuals and so forth. Well, as a provider, which I was a provider for about 10 years, the provider can waive that cost sharing. The MCO can also waive that with the approval of DMS. You can also, when I was a nonprofit, I raised money to help compensate that who could not afford those co-pays. And then also, you can also set up some type of a payment plan for somebody to pay that over a specified period of time. So that's basically what the cost sharing. But let me also let you know that there is provision there that codifies a cap. So basically 5% of the person's income cannot exceed that. And this doesn't apply to people below 100% in terms of the federal poverty level. Eligibility is the second. That's basically sections 5 through 9. Eligibility basically is folks that every 6 months we need to go through and have people to verify that they're still qualified for this. Let me address one thing. They're saying like, what's going to happen? It's going to increase costs, in terms of administration and those sorts of things. According to DMS, 85 to 90% of the individuals who go through redetermination, it's passive. They go ahead and it's qualified. So that leaves a very small group of individuals that will basically go through in terms of making sure they're qualified. If somebody is to be disenrolled, then there's an appeal process in order for somebody to go through and address that. The third thing, the next item is MCO contracts. That's managed care organizations contracts. We basically are codifying a lot of language in the contracts in order to make it more enforceable, to make sure that the MCOs are abiding by what's in the contract. Right now, DMS, what we can determine from the Medicaid Oversight Board, there's very little oversight and enforcement of these contracts, and hopefully this will be codifying that to force those particular activities. In the MCO's contracts, if there are fines that are applied in terms of finding somebody or finding an organization deficient or penalty, it will go into an account, or basically a restricted account called the MCO Compliance Fund. That money that goes into there, hopefully, it's our intent, is to have that fund and support reimbursement rates across the board. Non-emergency medical transport services. What that basically is non-emergency medical transport, it takes on some features of the Medicaid, managed care organization features. It withholds a 2% for performance in terms of the payments and making sure that the individuals are following the performance and making sure things are laid out in terms of providing those services as they're supposed to be doing. The other is called a medical loss ratio. I don't want to get in the weeds, but basically, thinking of it this way, it's basically it's an efficiency standards in terms of how much money is being allocated to those individuals that are providing a service. In other words, in the bill, it has a 90%. There are 16 regions, and there's quite a few brokers, and the brokers on average maintain a 91% marginal loss ratio. This means that 91 cents goes directly to the service, and basically 9 cents will basically be there for them to cover their overhead. So that's what that's there for, in order to try to get more accountability and make sure that our dollars are going toward the services of non-emergency transport services. Next, I would like to talk about, which is section 15 and 16, which is waivers. The waiver program, let me try to put this in perspective for you. 30% of the total Medicaid budget is spent on this portion of the program, which is 10% of the total Medicaid enrollment. So there's a significant amount of money going to a small group in the population. But that group has a lot of special needs, a lot of things we need to be mindful of and be careful of in order to make sure that they are getting their services. In there, we've got around 16,000 people on the waiting list. 16,000, so it's quite a few. So what the process basically reveals is that anybody can go and apply and get on the waiver list. But what the situation comes up is when on a waiting list, they can sit there for 2, 3, for many, many years. And there is also is not a priority list in terms of looking at acuity of that individual. And so what we're doing is basically having the administration go through and do an assessment of the needs in order to look at those higher priority, higher acuity individuals in order to take care of them. I do want to point out that of that waiting list, there's 94% of those folks that are on Medicaid. So even though they're on the waiting list, they're still receiving Medicaid services. Nobody's being disenrolled of them whatsoever. The other part of this is to help expedite the process. There is a physician attestation. So basically, when somebody comes in and wants to be on the waiting list, we like for them to get to see a physician to verify, to validate their needs and so forth, and that will help in the process in terms of expediting the decision in terms of what they need and what resource they will that they will go into. In addition to that, we've also established emergency slots for all waivers. Right now, the only one is the support community living. It has a special waiver in terms of emergency slots. So this provides more emergency slots in order to help those individuals out. The next item is dental services. In working with the Kentucky Dental Association, they would like to request basically setting up an administrative service organization, and that basically is a new model. Unlike with the MCO, which they're currently under, to have a new model in terms of administration service organization, and that basically provides us a little more control and input on how things are processed, how things are handled from an administration point of view. In addition to that, and I've been working with the chair as well as the vice chairs, that the other concerns that they have is reimbursements. That's probably a big issue because we're seeing a lot of attrition happen when it comes to having dental services, particularly in the eastern part of the state. And so we're working on that as well. It also includes the administration hiring a dental director. Right now, there is not one. I think they're trying to get somebody to come on board, but we're trying to make sure that materializes. The next item is data sharing. Data sharing is going to be a relationship or an agreement with the administration. And we will take in consideration HIPAA as well as confidentiality, but it will help the legislative branch in terms of policy and funding to make sure that we can have the most accurate and timely information in order for us to help make that decision. So that's what the data sharing is about. In terms of transparency and looking at benchmarks and those sorts of things, sections 19 and 20 deal with a healthcare dashboard. This is going to be driven as a subcommittee of the Medicaid Oversight Board, and the two organizations are going to be UK UVL, and they're going to be basically driving the design and development of a web-based dashboard that will be a centralized data source and not sort of a fragmented approach. And that's not a bad context or a bad thing to say. It's just basically trying to consolidate all this information to really be more targeted for Kentucky. Audits. Section 21 to 22, audits. There has not been a comprehensive audit when it comes to Medicaid services. We have seen quite a bit of concerns when it comes to how things are processed, how things are handled. And I'll give you an example. I literally sat in front of an individual with a staff employee with me, and we witnessed somebody being qualified after they go through and fill out the documents to be $44,000. That's a month. So $44,000 a month that they got qualified for Medicaid. And I sat there and saw it. This will help flush those things out in terms of an audit. Medicaid impact statement, which is 23. Be honest with you, we are our own worst enemies. We have probably around 32, 33, 34 Medicaid-related bills. And we need to have attachment of a impact statement for each one of those bills to see exactly how it's going to affect our budget, but also how is it going to affect the individual, making sure the services are delivered. The rest of the things has a regulation notice in there, and also has an emergency clause and other boilerplate language. It also addresses a GLP-1 drug coverage, and in terms of that, this cannot be used strictly for weight loss only, but it has to have other underlying circumstances and issues and so forth. Mr. Chairman, I've gone over a lot of here. I know it's a lot to digest. I guess the bottom line to me is that we need to breathe new life into Medicaid program. We need to look at how we're going to sustain this program in the future. We have to take on what's being handed down from the feds, like it or not. We've got to deal with it. And so this bill basically helps address those particular areas. And like I said, this really helps out in terms of program integrity. It provides transparency, it provides accountability, it puts more controls and oversight of the process, and it helps us to have a better program in order to deliver better services to those who are least among us.
Motion on
House
the
Bill 2 is amended by PHS 2 and the committee amendment.
second.
I have a motion and a second. And before we take that up, I have 4 people that I see have signed up to speak on House Bill 2. I think it would be good if we went ahead and hit those now, if it's okay. We'll take up questions at the end. And look, we are all on a clock, so we'll do this as effectively and efficiently as we can. First on the list I have is Emily Beauregard. And if you will come on up to the table, have a seat. Make sure the microphone is really green and lit up. Make sure it's close enough to you so we can pick you up on the record. And then once that's there, if you'll introduce yourself for the record.
Hi, good afternoon. I'm Emily Beauregard, Executive Director of Kentucky Voices for Health, and I want to thank Chair Petrie and members of this committee for the opportunity to speak
Very
about
good.
the...
If you'll hold just a second, if you'll raise your right hand, do you swear or affirm to tell the truth, the whole truth, and nothing but the truth?
I do.
Please proceed. And we
About
need to keep it quick, okay?
The impact of House Bill 2, the Kentucky Medicaid Reform Act. Medicaid has become the cornerstone of Kentucky's healthcare system, supporting the economic stability of every community, keeping the doors of our rural hospitals open, and caring for the majority of our loved ones in nursing homes. As the Kentucky General Assembly navigates federal cuts to Medicaid made by Congress through the One Big Beautiful Bill Act, the reforms proposed in House Bill 2 will be even more consequential. House Bill 2 incorporates many recommendations from the Medicaid Oversight and Advisory Board that we support: greater data transparency, improved dental access, more accurate tracking of provider networks, guardrails for provider audits, and stronger incentives for quality and performance. House Bill 2 also makes changes necessary to comply with the Big Beautiful Bill's new community engagement requirements, 6-month redeterminations, and copays. But as currently written, House Bill 2 goes further than federal law requires, even as states continue to wait for CMS to issue guidance through final rules. While there's no question that we must comply with federal law, it's important to ensure that House Bill 2 strikes the right balance to protect our healthcare safety net, to keep eligible Kentuckians enrolled, and to ensure that copays don't reduce access to critical care. Unfortunately, the Big Beautiful Bill didn't create exemptions for people based on their health status, which means that the $20 copays in House Bill 2 will fall hardest and most frequently on the people who need care the most. Here's a concrete example. Consider a family of 4 making just over $33,000 a year. Both parents are eligible for Medicaid expansion. The dad is working. The mom is currently unemployed because she's undergoing treatment for breast cancer. Her diagnosis makes her exempt from the work reporting requirements, but not from the copays. Based on her income, she could be charged as much as $1,650 in copays for the year. Her treatment for depression is exempt because that's a behavioral health service, but her biopsy, surgery, weekly chemo, blood tests, physical therapy, and medications are all subject to copays. Her providers ask for the copay at the time of service, and they have the right to refuse care if she can't pay that day. For cancer care, you would have to hope that most providers would choose to waive the cost, but $20 on repeat for multiple visits, labs, and PT every single month adds up quickly at a time when providers will be stretched thinner due to the federal cuts in the Big Beautiful Bill. As legislators continue to explore the right approach to implementing and monitoring these new federal requirements, it will be critical to understand first who will be subject to copays, how many people with a serious illness like cancer or a chronic condition like heart disease or diabetes would be required to pay $20 for most of their specialist visits, their tests, and treatments. Before this legislature voted to end Medicaid copays in 2021, how many patients were turned away from an appointment or denied a prescription for inability to pay up front? And what did it cost providers to collect those copays? These are important questions to consider, and there's no need to rush.
2-minute warning.
Okay. The MOAB could spend the entire 2026 interim exploring these questions and settling on the right approach to copays, including the amount to charge, how to collect those payments before passing legislation to comply with the federal law by October of 2028. And if House Bill 2 maintains the copay provisions, consider taking them down to $1 or leaving it to the regulatory process to set the rates. Either of those approaches would comply with federal law. Eligibility verification may be even more critical to get that balance right, but I'll leave that to another person to testify with their expertise. And I'll end by saying, as you deliberate over changes to House Bill 2, please take these 3 key steps as you seek to strike the right balance with the reforms that are currently part of this bill. First, align any changes to data checks, eligibility paperwork, and copays in House Bill 2 with the premiums required by federal law. Second, reserve as much state flexibility as possible for forthcoming federal guidance that we expect to be released in June. And third, closely monitor the impact of these changes on enrollment, utilization of services, and health outcomes in order to make data-driven decisions about future reforms. Thank you.
Very good. Thank you. And thank you for keeping it well under time. Appreciate that. If I may, just for clarification, your comments addressed to House Bill 2, are they also addressed to PHS 2 as amended by Committee Amendment 1, or is it generically on House Bill 2?
Having looked over PHS 2 and hearing the explanation of Committee Substitute 1, I believe that these are still relevant. Those changes weren't made.
I want to make sure that everyone's got
thank you for
that.
asking that question.
Thank you very much. Next up on the list, I have Jason Dunn. Well, I've had communications with Emily before. I'm not sure about Mr. Dunn. And there's nothing listed as an organization, so I can't reference that. I'm sorry.
Right.
But if you will, if we've got about 5 minutes, if you will first introduce yourself for the record, make sure the microphone's sufficiently close to you and the green light is really green.
Sure is. All right, my name is Jason Dunn. I've been to these tables a lot. These are 2 firsts for me today. It's my first testifying to an A&R committee, and it's my first as a private citizen.
Very good. Very good. If you will, raise your right hand.
Absolutely.
Do you swear or affirm to tell the truth, the whole truth, and nothing but the truth?
I do.
Please proceed.
Okay. So good afternoon, Chairman Petrie and members of this committee. Thank you for this opportunity to discuss House Bill 2. So my name is Jason Dunn, and by way of introduction, I spent over 30 years with the Cabinet administering public assistance programs, which included working with Medicaid eligibility. So because eligibility was my slice of the Medicaid program, that's where I'm going to limit my comments to today. So I've seen firsthand.
And if I may, just
sure.
like I followed up with Emily,
Sure.
your comments addressed to House Bill 2 or PHS 2 as amended by Committee Amendment 1, which one, so the members know?
The committee sub.
Okay, thank you very much.
Yeah.
Please proceed.
I've seen firsthand the impact of rules that create access barriers for otherwise eligible people. They lead to denied or delayed access and contribute to application churn, adding burdens for recipients and higher costs for the state. I'll briefly touch on some of those that we found in House Bill 2. The data matches in Section 5, or the first couple of things address data matches in general. They can lead to unnecessary loss of Medicaid coverage if a mismatch between data sources can't be easily resolved. The only remedy to this is through an appeals process that already takes months and is likely going to take longer when more people have to appeal. Some specifics about that: the Paris matches are mentioned in there. That's the Public Assistance Reporting Information System. Those are updated quarterly, so the information in those matches is sometimes up to 6 months old. Often the cabinet may have more recent verification that refutes that, but things can get lost and errors can be made in addressing those. It also mentions the Transformed Medicaid Statistical Information System, which is a mouthful. That is designed for states to use for eligibility, but then the next item on that list is an analytic file. That's for research purposes, and it's not really used in an eligibility determination, so it likely shouldn't be included in the bill. Section 7 adds more to the list of required matches, but whether or not the information is valuable in those matches, subsection 14 requires the cabinet to initiate a full redetermination, which is in addition to any regularly scheduled redetermination. So that's just adding another step, adds more red tape. It exceeds the requirements of federal law, and these data sources should first be studied to determine their value in the eligibility process. And then in Section 10, subsection 3, there's a requirement to discontinue any Medicaid recipient's coverage if there's returned mail and the MCO doesn't provide a new address in just a small window of 14 days. This provision will disproportionately impact individuals who are homeless and people who are housing insecure who may have been recently evicted. In any case, bad addresses require more outreach before someone loses coverage, and that's based on federal law. So throughout my career at the state and federal levels, I've always kept an eye on program compliance and fraud. However, there's always a balance to strike between access and over-verifying eligibility, particularly when it's not required by federal law. These sections of House Bill 2 miss this balance, valuing program integrity at the expense of access to otherwise eligible Kentuckians, trying to navigate through the red tape.
A minute and a half warning.
Thank you. At the same time, the agency will spend more to serve fewer low-income Kentuckians. And this doesn't make us any healthier and ultimately may not save us any money in the long run. And one other word of caution: when implementing a new sweeping law like the federal H.R. 1, moving too far out beyond federal requirements without guidance from the implementing agency is a risky move for states. I saw this with welfare reform in 1996. Kentucky took a conservative approach until guidance was released, and that took 2 years to come out. With that approach, we were in much better shape to accurately implement the law than states who went their own direction. I urge the legislature to make that same conservative approach to the implementation of the Medicaid portions of H.R. 1 by not going further than what it calls for until we know more from CMS. And a brief personal note that I haven't written down on here: I'm a Kentuckian living with MS. I'm thankful and blessed to have good insurance to cover those costs. Kind of piggybacks on what Emily was talking about, but if I'm a Kentuckian living on the edge of poverty, $20 to see specialists, get our MRIs, get blood draws that I have to do regularly, I may have to skip those or make hard decisions about whether I pay that copay or pay my utility bill. So I wanted to leave that on, and thank you all for listening.
Thank you very much. Next up, we have Jim Lacefield. Very good. And as those before you, if you will, make sure your microphone is lit up really green at the base. It's up close enough to you. And if you'll introduce yourself for the record, please.
I'm Jim Lacefield. I'm part owner in Venture Cabs in Corbin, Kentucky.
Very good. If you'll raise your right hand. Do you swear or affirm to tell the truth, whole truth, and nothing but the truth?
Yes, I do.
Very good. And as everybody else has done, 5 minutes or less if we can, and I'll try to give you a little bit of warning.
It'll be quick. I didn't know I'd have an opportunity to speak till I got here today.
You're good. Thank you.
So currently I have 20 employees in Corbin, Kentucky. 95% of our revenue comes from being a subcontractor for one of the brokers, our broker being Artec. And let me back up. What I'm speaking to is House Bill 2, Section 14, as it refers to the MLR being changed from 85% to 90 with a chance to earn back that another 2%. That metrics will work great in Louisville. I've been in transportation and logistics for 30 years. It will not work in our rural communities. If you're not in Lexington, Kentucky, Louisville, Kentucky, and a metro city, we won't have the opportunity to get that 2% back. The transition that will happen when these brokers are forced to close their doors, and it will come to that at 90%. When they close their doors in Whitley, Laurel, and Knox County, I believe there's around 70 vehicles running Monday through Friday. When those doors are closed, just in my Tri-County area, there's hundreds of people that are affected. The transition to get in more subcontractors and another company that thinks maybe they can make it work will take months. I have a 16-year-old who now has become part of my family that I met through this program. I personally bring him to Lexington every Friday. He spent over 180 days in the hospital, less than 5% chance he would ever leave. We've been on chemo for 2 years. We see no end in sight. He needs open heart surgery, the dental. They don't cover all the root canals that he needs because of the chemo. He's legally blind because of the chemo. We stay on the verge of organ failure. When we say NEMT and we use the term non-emergency medical transport, it's only non-emergency medical transport because we don't have life-saving equipment or life-sustaining equipment in our vehicles. But a lot of what we do is emergency, and it has to be done. The number of people we take to dialysis, the number of people that we have to transport from close to the state line in the south to Lexington to see a cardiologist, neurologist, or for cancer doctors, to see specialists. It is an emergency that these people are hauled. The federal government's target rate is 85%. And we're trying to, as the bill stands right now, Section 14 is to move it to 90. It's going to be a death sentence for my family-owned business, along with dozens and dozens more just like it, to also include the brokers. We're talking about thousands of jobs and the loss of service to a lot of people. And there will be loss of life during transitions. Thank you for your time.
Thank you very much. And I know that issue's been discussed with the sponsor and others, and I think it has been a small bit of a moving target, not because anybody's done anything wrong, but trying to get to all NEMTs and determine what's necessary and not necessary and works. And I know that some accommodations have already been made. I've got a feeling that issue will continue under consideration for better fielding it across the entirety of the Commonwealth.
Across the entire state.
Yeah.
Thank you.
Thank you very much.
And thank each one of you for your time.
Thank you. Next up, I have Maggie Chisholm, Heart of Access. And as those before you, if you will make sure that the microphone's sufficiently close and the green light is really green on the base, if you'll introduce yourself for the record.
My name is Margaret Chisholm, but I go by Maggie.
Very good. If you'll raise your right hand. Do you swear or affirm to tell the truth and whole truth and nothing but the truth?
I do.
Very good. We'll try to keep it to 5, and if you will proceed, please.
Thank you.
And as I've asked some of the others, are you speaking to House Bill 2 or PHS 2 as amended by committee amendment, or both?
House Bill 2.
Very good. Thank you. Please proceed.
Thank you. As I mentioned, my name is Maggie Chisholm, and I am a Kentuckian, an advocate, and a mother. I am also someone who has learned through loss what happens when policy changes move slower than real life. When we talk about policy change, it's easy to point fingers, but real progress requires honesty and collaboration. Because while debates continue, people are facing barriers, getting sicker, and some are dying. Optimism is a privilege. Rest is a privilege. Waiting is a privilege. So I need to ask, what about the people who don't have the luxury of waiting? My daughter Evie was one of those people. Evie was born on September 7th of 2016 with hypoplastic left heart syndrome. Basically, only half of her heart was functional, and by the time she was 4 years old, she had already undergone 3 major open heart surgeries. Evie was also on a Medicaid waiver for the majority of her life due to her complex medical needs and compromised immune system. Despite her extensive medical history, I had to fight every year just to get her waiver renewed. It was exhausting and time-consuming, and the amount of paperwork required was overwhelming. But I did it. I did it because there was no room for inaction. On August 26th of 2024, at 7 years old, Evie was hospitalized for heart failure and placed on the heart transplant list. In September of 2024, while she was fighting to survive, I was notified that she was going to be removed from her Medicaid waiver because she was not, quote, utilizing services. Let that sink in. My child was dying, waiting for a heart that never came, and I was told her coverage might be terminated because she was too sick to use it. The very condition that qualified her for care was being used to justify taking it away. In that moment, resting was not an option. Waiting was not a luxury I could afford. Advocacy was not a choice for me. It was survival. It was a battle I fought while being swallowed by fear and despair, because doing nothing would have meant losing everything. I fought because my child's life depended on it. In my family's case, Evie passed away on November 13th, 2024, before her coverage could be taken away from her. And yet, to add insult to injury, 13 days later, on November 26th, just 5 days after I buried my daughter, I received a text message reminding me that her coverage would be canceled on December 1st. I had to explain through my grief that she had already died and they could remove her from their lists. Mine is not an isolated story. There are countless stories of children, of parents, of individuals who do not have the privilege of waiting for systems to improve. People whose lives are measured in days and decisions, not fiscal years. The system is already failing Kentucky families in its most fundamental promise to protect those in need, to protect our most vulnerable populations. Kentucky families are being pushed to emotional and financial limits by a system intended to support them. So I ask again, what is being done for them? Are they even a part of the conversation? Who are we building policy for? How many people are we willing to lose on the path to progress? And what number, if any, would be considered acceptable? I recently heard someone say at a conference I attended, if you're not at the table, you're part of the meal. But what about the people who are not in a position to be at the table? What about the people who don't even know the table exists? Because access to information is not equal, and the majority of Kentuckians who will be affected by these policy changes are likely not in a position to attend conferences and committee hearings. In this state, entire communities remain disconnected digitally and from equitable participation. People who cannot get online, cannot show up, cannot advocate, cannot organize, cannot even access critical information because the infrastructure simply does not exist. So many Kentuckians are already invisible, not because they don't matter, but because we failed to see them. When we add stricter requirements, more frequent redeterminations, and more paperwork, we do not create efficiency. We create barriers for families already fighting to survive. to even be acknowledged, and we cripple a system already bottlenecked with the policy expectations we place on it. Kentucky families deserve stability. They deserve dignity, and they deserve a system that that protects them when they are at their weakest, not one that forces them to fight for the right to survive. Families need to receive clear advance notice with real time and meaningful opportunity to respond before they lose coverage. I'm asking you to make sure no other family has to fight the way mine did, to not force Kentuckians to pray for a miracle that they have no idea how they will pay for. Because when access is unequal, participation is unequal. When participation is unequal, policy outcomes follow the same pattern.
Ms. Kism, we're well expired on time, and I've gone past. In respect,
I just have one sentence
in respect
left.
to the other ones, I just wanted to, the other speakers that came before you. So thank you. Please proceed.
And if our policies only work for those who can wait, who can log on, who can show up, then it is not working for the people who need it most. Thank you.
Very good. Thank you very much. And thank you for coming in and speaking on personal matters also, and that's hard to do in a family setting and even harder to do it in a public setting. Appreciate it.
Thank you.
All right, thank you very much. And any members seeking recognition, I think that's all the speakers we had that signed up. I have Representative Bojanowski.
All right. So first of all, Representative Fleming, I know that you have put a lot of time and work into this. It's a very complex subject that I am only beginning to understand a tiny bit about. So I do appreciate the work that you've done. My question is regarding the personally identifiable information. And could you explain the reasoning behind not allowing Kentuckians using Medicaid a chance to confirm their personal information? It says, for conflicting data sources, a notice of ineligibility would be issued with a right to appeal, which could take months. And for people with disabilities, or like Ms. Chisholm with a daughter with a chronic disease, it could be devastating. So why do we immediately have them become ineligible with a chance to appeal rather than giving a 30-day window perhaps?
How are they ineligible immediately?
Well, they would get a notice of ineligibility. Is that correct?
Notice, and then they'll get a notice,
Okay,
and then
hold on a second. I want to make sure we do this in a way that everybody can follow. So
Sure.
I've got
Sorry,
a
Mr.
question that's
President.
asked, then I've got a response that's given, and then we'll see if there's another question or comment. All right. So
Sorry.
Okay, so to finish my question, so
Sure.
I'm coming at this from the perspective of a parent who does the paperwork for my son's Medicaid. It's not included under here because he's non-expansion. But he works, he does what he's supposed to do. It's my understanding that a lot of the people who will lose coverage will lose it not because they don't comply with the requirements of the community service or community engagement, but because they don't complete the paperwork, which is exactly where my son does. It lead them to ineligibility with the chance to appeal as opposed to allowing the individual to provide feedback to correct perhaps misinformation?
Mr. Chairman, first of all, let me before I address your question, I'm going to address the lady who just testified and her daughter passing. May I do that, Mr. Chairman?
is it in response to Representative Bojanowski's question?
No, sir. I just want to respond to that. Okay, I'll say that. So your question that they're going to be immediately taken off. They will receive a notice that they need to go through and verify their status. Yes, there is an appeals process to go through that, but they will not be taken off immediately.
Okay, thank you.
Mm-hmm.
Representative Burke?
Thank you, Mr. Chair. A question?
Yes, please.
Thank you.
some fraud activity in terms of all that. So we want to get a handle on that as soon as possible in order to get a better understanding of any potential fraud that might be out there. So that's why we want to accelerate that.
May I ask one last question?
Yes, please.
Are those the only two elements then that are out of sync with what's required under One Big Beautiful Bill?
I'm trying to think.
I do want to make sure, Representative Burke, out of sync doesn't mean it's contradictory to it. It just may vary within the bounds that are allowed. Is that what you're getting at?
My question specifically is what requirements are higher or more stringent than what is required by federal law?
I think I'm trying to remember. I think those are the couple of things that I mentioned in terms of what might be accelerated in terms of the federal law.
Thank you for your answer.
Anyone else? Representative Stevens.
I just have a question. I had a constituent who asked me to loan him $12 because he missed his last two dialysis because he couldn't afford the bus fare to pick him up. My question is, there are lots of situations like that in the city of Louisville. Why is this bill more towards catching criminals than making sure people have health care? Because most of, as we've heard, most of the provisions are kicking people off, stopping people when they're at their weakest, when they're sick, and you want them to fill out 20,000 pages.
Okay, I'm going to go back to
So I asked the question.
Yeah, hold on a second. So as we're asking questions, and if we've got a comment, let's make it. If we've got a question, let's make sure we pose it. Please proceed.
I asked him the question. He looked at me, so I clarified it for him.
Go ahead and restate your question, please.
Why is this more contingent on catching the wrongdoer, which we should catch, than giving people who need health care? Because as far as I can tell, if you're in this body, you're going to need health care.
There's emphasis on continuing to provide the care. It's always been there. That's always been the emphasis in terms of making sure people are getting their care that they deserve and so forth. This applies to expansion individuals only in terms of House Resolution 1, and so that particular individual, there's the emergency transport services. If he is going to get a dialysis, he can go through and get that. They will get compensated in order to make that possible because it's Medicaid related, and so he doesn't have to go through to use a public system. He can use the emergency medical transport.
Thank you.
Thank you. Any other members seeking recognition for comment or question? Seeing none, we have a pending motion on PHS 2 as amended by Committee Amendment 1 on House Bill 2. We have a motion and we have a second. No other members seeking recognition, please call the roll.
Representative Banta.
Yes.
Representative Bojanowski.
No.
Representative Bowling.
Yes.
Representative Bragg. Representative Bridges.
Yes.
Representative Brown.
No.
Representative Burke.
No.
Representative Dietz.
Yes.
Representative Fleming.
Aye.
Representative Freeland.
Yes.
Representative Fugit.
Explain my vote.
Yes, briefly, please.
I'll pass this time due to concerns with the transportation portion. Thank you.
Understood. Thank you.
Representative Hart.
Yes.
Representative Lockett.
Yes.
Representative McPherson.
Yes.
Representative Riley. Representative Stevenson.
No.
Representative Thomas.
Aye.
Representative Truitt.
Explain my vote briefly.
Yes, please.
Representative, I appreciate the time you gave to hear our concerns. Today I'm going to pass, but I welcome some more conversations to see if we can work out some of the details we had. So thank you.
Thank you.
Representative Upchurch. Representative Williams.
Yes.
Chair Petrie.
Yes. House Bill 2, as amended by PHS 2, as amended by Committee Amendment 1, having received 14 yeses, 4 noes, 2 passes, will be reported with favorable expression that same should pass on the floor. And we have a Committee Amendment 1 and a PHS 2.
Motion to roll the committee amendment into the committee sub. Second.
We have a motion and a second to roll the committee amendment into the committee sub. All in favor? Aye. All opposed? It is so rolled. We now have amended bill rolled together, PHS 2 and Committee Amendment 1 thereon. Thank all the presenters. Thank all the people that came in and spoke. Thank you all for attending, and we are adjourned.
Appreciate it.